you have to remove it. Can you stop the share screen?
Okay, stop sharing video, yeah?
Yes, thank you.
Okay.
All right, perfect. So let everyone inside. There you go, everyone. All right, so good morning, everyone. Welcome back to our international ground rounds. Today, I'm very glad to have Professor Narayanan, Prepageran from Malaysia. Good morning.
Hi, good morning. It's evening for us. It's 8:30 at night. Good evening.
Yeah, no, I'm used to saying that good morning to everyone. It's because over here is 2:30 p.m., but people are joining from worldwide. So I guess over there, what time is it in there?
It's 8:30 at night now.
So
we're 6 hours ahead.
Today's a special occasion. I've heard the possibility to listen to a few of the talks from Professor Prepageran during the Milano Masterclass back in 2015 and before, and I was fascinated by his skills in anatomical dissections and cases. So I requested him just recently to discuss few of his step-by-step anatomical dissection videos, and today he's going to talk about the approaches and the anatomical dissection of the pterygopalatine fossa, of the infratemporal fossa, and back to the Meckel's cave. So if anyone is interested to get more information regarding this, I would like to also say that Professor Prepageran has his own, from the university program, has his own YouTube channel, and you can go there and watch his beautiful demonstrative videos. So are you ready?
Yes, I am.
Okay,
thank you.
So please, let's share the presentation, and I will give you the torch completely. For all the attendees, please do remind that questions should be asked at the end of his presentation.
Thank you very much. So I'll be speaking about the pterygopalatine and infratemporal fossa and Meckel's cave. So what makes surgery in this area difficult? So some textbooks or literature actually says that the infratemporal fossa is probably one of the most complex anatomy in the human body as well. It requires a 3D understanding because it's got a potpourri of nerves, muscles, vessels, and bone. And can you all hear me? Is the screen being shared?
No, the screen is not shared already. But sound is fine, completely fine.
But how do we, let me just get the, okay, let me share the screen again.
Yeah,
okay.
Sure. There you go, perfect. So
perfect, okay. Sorry about that, yeah. So basically, what the outline that I'm going to do is I'm going to do we show you anatomy of the pterygopalatine fossa, the infratemporal fossa, and then I will show you videos of near live dissection, which is basically with very minimal editing. Basically, the idea of doing a dissection is basically to do like pilots, how they do a flight simulation, where they try to have a test run. So a dissection should be done the same way as if we are going to do a surgery. We should do the same instruments, dissect in the same planes, preserve the muscles and the delicate structures that we're going to preserve in surgery. And then I will also show an overview of the anatomy of some of the dissection that I've done. Sometimes repetition is good because it shows the different anatomical configuration in different cadavers. Then I'll move on to the Meckel's cave with the same format as well. So let's start with a scan. So basically, the pterygopalatine region will be this region here. This will be the pterygoid plates. That's the posterior wall of the maxilla, the middle pterygoid, the lateral pterygoid. And here you can see the middle pterygoid, the lateral pterygoid muscle, the medial pterygoid muscle, that's the temporalis muscle. So this will be the pterygopalatine fossa, and this will be the infratemporal fossa. The infratemporal fossa can be quite complicated, but again, from the scan, as you can see, the first muscle that you will see, if you go lateral enough, will be the temporalis. Then you will see the lateral pterygoid, and quite only very occasionally be able to see middle pterygoid because it's quite low down. So let's start with some anatomical dissection. Here is the infratemporal fossa that is lateral to the pterygoid plate. So this is the pterygoid body that contains the middle pterygoid, the lateral pterygoid. So the definition of the infratemporal fossa will be anything that is lateral to the lateral pterygoid. So this will be the infratemporal fossa, and this will be the pterygopalatine region here. Here you can see how the maxillary artery that is divided into 3 portions by the lateral pterygoid, the mandibular division, the pterygoid division, which is lateral to the lateral pterygoid itself, and how the maxillary artery actually gives out the descending palatine. And once the artery gives out the descending palatine, then it becomes a sphenopalatine artery, as you can see. And that's the V2. The V2, if we trace it backwards to its origin, it takes us to the foramen rotundum, and this will be the Redian's nerve. So the conductor of the orchestra of the entire infratemporal fossa, the artery will be the maxillary artery, the nerve will be the infraorbital nerve, the muscle will be the lateral pterygoids. You can just about to see the lateral pterygoids here. Here, you can see how the temporalis muscles are exposed, as you can see. Let me just move this to the side. Yeah, perfect. Here you can see how the temporalis muscles are exposed. And here you can see the middle pterygoid muscles, the infraorbital nerve to the V2, again, the internal maxillary artery to the IMAX, the descending palatine, and then it becomes a sphenopalatine artery. So to remember, the best way to remember the muscles of the infratemporal fossa is to start from the lateral. From the lateral is always temporalis, then we'll come to the middle pterygoids, and only if when we remove the lateral plate or the lateral pterygoid, we'll be able to see the middle pterygoid. So it's temporalis, lateral pterygoid, and then middle pterygoids. In my simple mind, the way I remember it, especially in real life surgery, when there's oozing and all that, is to see the way the fibers run. The temporalis muscle, the fibers will always run vertically from the top to bottom, whereas the lateral pterygoid muscle, the fibers will always run almost horizontally. The superior one will come obliquely downwards, and the inferior head will come obliquely upwards. And the middle pterygoid is usually will not be able to be seen in the endoscopic infratemporal fossa because it's actually much lower down. So that way, it's quite easy to remember the muscles. So this is another view once the temporalis muscle has been exposed. And again, you can see the lateral pterygoid, as you can see here, the maxillary artery that's coming across. This is the branch that goes along the infraorbital nerve, the descending palatine, the sphenopalatine. And this is now only the exposure of the infratemporal fossa. And here you can see how the superior head of the lateral pterygoid, and this is the inferior head of the lateral pterygoid. The superior head of the lateral pterygoid comes from the wing, from the sphenoid wing, whereas the inferior head comes from the lateral aspect of the lateral pterygoid plate. And you can see, as I described before, the fibers of the superior head run almost horizontal downwards, whereas the inferior head runs horizontal but slightly upwards. That's how I identify this muscle in live surgery as such. So this is a view once the superior pterygoid, the superior part, the lateral pterygoid has been reflected. And this is how I will identify V3 in my dissection. And this is after the pterygoid muscles have been removed and the floor of the lateral recess has been drilled out until foramen ovale. And you can see how the posterior branch of the V3 runs between the 2 heads of the lateral pterygoid muscles as well. Here you can see how the foramen ovale, and these are the V3 as well. These 2 branches are the branches of the supplies, the middle pterygoid muscle. And these branches will be, the posterior branch is called LIA, L-I-A. It's a song by Toto. I'm sure some of you who are old enough will remember the song by Toto. It's lingual nerve, auriculotemporal, and inferior alveolar. And a close-up view of the lingual nerve and auriculotemporal. As you can see, that's the middle pterygoid. And you will only see this once you remove the lateral aspect of the lateral pterygoid. Otherwise, you will not be able to see the middle pterygoid. And this shows the lingual nerve and inferior alveolar quite nicely. And then if we go a bit closer, you can see how the chorda tympani actually joins the lingual nerve. This is the middle pterygoid muscle as it supplies taste into the tongue as well. So again, this is after removal of the lateral plate of the pterygoid. Only then you'll be able to see the middle pterygoid muscle. And you can also see the tensor valley palatine. And this is the venous plexus or the pterygoid plexus that is seen in the infratemporal fossa. And dissection of this area during surgery can cause a lot of oozing and bleeding. And sometimes infection of this area can also go up to the cavernous sinus because there are communications by the venous plexus from this region of the pterygoid plexus that goes up to the cavernous sinus without any walls whatsoever. So now let's go on to the dissection. Again, the dissections I do is like a flight simulation. I do it like how I would like to operate so that when you do surgery, it becomes much more smoother. I tried my best to use the same instruments and to go in the same plane by plane manner as well. So this is endoscopic middle maxillectomy. Hold on, so let me just make this softer. Okay, here you go. So what I'm going to do now, we do a middle maxillectomy first. So again, the first thing we do is we cut the inferior turbinate. And as we cut the inferior turbinate, it's very important that we keep a posterior stump of the inferior turbinate intact. This is simply because the inferior turbinectomy can have torrential bleeding. And if you leave a small stump behind, the caliber of the vessel that comes down or the turbinate artery is much smaller. And then the bleeding is much less as well. And then what I usually do is I find a soft spot in the inferior meatus, and then with the fierce elevator, push the entire medial wall of the maxilla laterally. And once this is done, by using a scissors, then we can go into the junction where the opening was made into the inferior part of the inferior meatus, and then cut across straight to the maxillary opening like this. And as we do this, the only part that we have to watch out for is the nasolacrimal duct. There as you can see, that's the nasolacrimal, that's the lacrimal bone, that's the nasolacrimal duct coming into view. So when we cut this, what we need to do, we need to cut this in an oblique manner. If we cut it in a horizontal manner, you can have epiphora. So I'm removing the lacrimal bone, where the lacrimal canal, where the lacrimal sac goes, and then we can easily cut off the other part. Then what is important is we have to identify the nasolacrimal duct. You can see that's the nasolacrimal duct, and then we need to marsupialize this to make sure that we don't get any epiphora. So then by using a sickle, we can cut the nasolacrimal duct and marsupialize this, and this will avoid any epiphora as such. Now let's go on to the module of the infratemporal fossa and the lateral viscerous sphenoid. So the first thing we need to do is to identify the sphenopalatine artery. And here you can see, to identify the sphenopalatine artery, it's at the same level as the posterior wall of maxilla. So all we need to do is go subperiosteally and dissect the submucosa away subperiosteally. And then there's only one structure here, which is the sphenopalatine artery. You can see the crista ethmoidalis, and that's the sphenopalatine artery coming across. And down here, you can actually make out an accessory artery here as well. It's probably coming from the descending palatine artery. So once we have identified this, we've opened up the middle maxillectomy as I showed just now. What we need to do now is to remove the mucosa of the maxilla. So once we remove the mucosa of the maxilla, we can actually make out the infraorbital nerve here. You can make out the maxillary artery, and that's the temporalis muscle, and that's the fat of the infratemporal fossa, as you can see. Infraorbital nerve, the maxillary artery, and the temporalis muscle here. The next thing that I would do is, the next step would be to use a Carrison punch to go into the pterygopalatine plane. That is to go between the posterior wall of maxilla and the body of the pterygoid plates at the back. So the dissection I do and the instruments I use is exactly the same as what I would do in real life surgery. And it's good to do it like that because then it gives you a practice as like how pilots do in a flight simulation. So just follow the sphenopalatine artery backwards. And quite often this part here is quite thin. And then by using a Carrison punch, we can easily remove the bone along the posterior wall of the maxilla. Very rarely this bone is thick. And then you can see the fat that is being exposed. That's going to infratemporal fossa. And again, we are removing all the bone. And that is now coming, you can see the descending palatine artery coming, and that's the branch that's coming there as well. And this gives us a view and the opening of the pterygopalatine space. Then what I would like to do is to follow the infraorbital nerve here. So I'm just going to remove the bone over the infraorbital nerve, and that identifies the infraorbital nerve. And then use a Carrison punch again to remove the upper part as well. So we can also go laterally. You can see the temporalis muscle coming into view here. So even by using a simple endoscopic middle maxillectomy, you can go almost to the junction of the anterolateral wall of the maxilla, and you can see the infratemporal fat, as you can see here. If we need more space, sometimes that we need to go almost up to the TMJ or zygoma, we can always do a Dankus. And now we can see the infratemporal fossa with the fat here, the temporalis muscle, and this is the fascia that's covering up the pterygopalatine. So I'm going to remove a little bit more bone, and you can see how I'm coming almost to the junction of the anterolateral wall of the maxilla itself. Right. The next step will be to open up the fascia. So I'm going to remove a little bit more at the top. The next step will be to open up the fascia and remove as far laterally as we can, so that we can expose the entire infratemporal fossa. So once we have that, now we can identify the sphenopalatine artery very nicely. Here you can see how the sphenopalatine artery is here. There's probably two branches, the posterior septal and the posterior or the lateral nasal part. The posterior septal part will go to the septum, and that's the infraorbital nerve. So what we need to do now, that's the fat in the infratemporal fossa. So what we need to do now is to open up the fascia that's covering the pterygopalatine fossa. When we resect this fascia, we can already make out and identify some of the vessels. It's always vein, artery, nerves. And in the cadaver, the veins would have collapsed. So what we're looking at is the maxillary artery itself. So even in real life, I would use the same sickle knife and then dissect and expose. And you can see the infraorbital nerve coming into view as well. And that is the maxillary artery coming into view. So what we need to do is to dissect the entire maxillary artery and to show the descending palatine as well. So here we can see the descending palatine coming into view down here. And then once after the descending palatine branch is out, then it becomes a sphenopalatine. And the easiest way to dissect the maxillary artery is to use a sickle knife and pull the artery forward gently. And that gives us a very nice view of the maxillary artery, the third part, and that is the descending palatine branch. And once the descending palatine branch, this becomes a sphenopalatine artery. So that's the maxillary artery dissection. And if we need to stop epistaxis, if you're bleeding from the hard palate, then we clip proximal to the descending palatine. Whereas if you need to stop bleeding from the nose itself, then we clip the artery distal to descending palatine. Maxillary artery, descending palatine, sphenopalatine, as you can see. And you can see how it curves in this direction. So once we have done that, the next step would be to identify the infraorbital nerve. Right, so here the maxillary artery has been dissected, and you can see the descending palatine quite nicely as well. Right. So next we would go to the infraorbital nerve. So what we're going to do now is to dissect and expose the infraorbital nerve. And again, you can make out the artery, the branch of the maxillary artery that goes along the infraorbital nerve, and that is the infraorbital artery that follows the infraorbital nerve. That is the branch from the maxillary artery. It turns along the infraorbital nerve and follows the artery as well. So what we need to do now is to dissect and identify the infraorbital nerve and follow it to its origin. As I mentioned before, the most important vessel or the conductor of the entire pterygopalatine and infratemporal fossa is the maxillary artery, is the infraorbital nerve, and the lateral pterygoid. So now what we need to do is cut the fascia superiorly. And once we cut the fascia superiorly, we need to follow the infraorbital nerve backwards until we're able to visualize. We may need to cauterize some of the vessels here, and then follow the infraorbital nerve backwards until it comes to the foramen rotundum. So now we are dissecting very close to the infraorbital nerve. We can already see the body of the pterygoid, and once we see the body of the pterygoid, remove the fascia around it, and that will take us straight to the foramen rotundum. So you can see the body of the pterygoid, and that's the foramen rotundum coming into view. That's the foramen rotundum there, as you can see, nicely seen. So once we have seen the foramen rotundum, what we need to do now, you can see the blood vessel that comes from the maxillary artery that goes into the infraorbital. That's the branch from the maxillary artery that goes into infraorbital and forms the infraorbital artery as well. The next what we need to do is to do and identify, that's foramen rotundum very nicely seen. Now we need to identify the Radiance nerve, foramen rotundum. So in the Radiance nerve, the dissection is always medial and inferior to the foramen rotundum. One method will be to go and dissect subperiosteally from the sphenoid itself and to come downwards. And then by doing that, we will be able to find the radian nerve. So that's the radian nerve canal, as you can see. This whole area is the radian nerve canal. And you can see how the canal, the radian nerve canal here, takes you straight to this whole area here is the radian nerve, and the canal is seen quite nicely there. Now I'm going to dissect and remove, that's the foramen rotundum, and that's the radian canal, as you can see. Is it clear on the screen, guys? You can see that quite nicely, yeah? This radian nerve. So what we need to do now, we need to dissect to identify the pterygopalatine ganglion. And that is not an easy dissection because sometimes it's not very clearly seen. You can see how the radian nerve takes you straight to the paraclival carotid. So when we do the dissection now, from the foramen rotundum, there's a foramen rotundum, and you can see how it goes along, the V2 goes from rotundum. And here you can see the two branches or the pterygopalatine nerve, the two of them. Can you see that? It's quite clear, as you can see. So these two nerves actually hold up the pterygopalatine ganglion, and it gets innervation from the Radiance nerve. It comes, the two nerves, 1 and 2, this holds up the pterygopalatine ganglion down here, as you can see. So this is the identification of the pterygopalatine ganglion, radian nerve, the pterygopalatine nerve that holds up the pterygopalatine ganglion, as you can see nicely, and that comes from the foramen rotundum as well. So let me just go a little bit quickly because the rest is basically to show the lateral viscera, which I'll show later. So this shows very nicely the radian nerve, the two branches or the pterygopalatine nerve, which I've dissected. And here again, you can see the foramen rotundum coming into view. That's radian, and that's foramen rotundum. Nicely seen, okay? So that gives us an idea of how the big eye of the radian, of the foramen rotundum, and this is the small eye of the radian nerve. Now let's move on to infratemporal fossa, all right? So now let's move on to infratemporal fossa. And to identify the V3, so that is the pterygoid body itself, the lateral pterygoid plate will run along this direction. So now we're going to dissect, that's the superior head of the lateral pterygoid. You can see from the muscle fibers. And if we go subperiosteally and dissect the superior head of the lateral pterygoid, we can go straight and identify, now we're in infratemporal fossa, and we can identify the V3. So that is the foramen ovale, as you can see. And that is the branch of the VT that's coming out. That's probably the posterior branch, and that supplies to the lingual nerve, inferior alveolar, and auriculotemporal. And that is the superior head of the lateral pterygoid, as you can see. So this gives us a dissection of foramen ovale. And now, if we remove the fat along the infratemporal fossa, we can actually visualize the temporalis muscle. You can see there's a lot of fat to be removed in this region. And here you can see the temporalis muscle coming into view. And how do I know it's the temporalis muscle? Look at the fibers. Look at the way it's running. It's running vertical downwards. And when we move the mandible, you can see the muscle moving as well. So that's the temporalis muscle. And you can see the direction of the muscle coming down in a vertical manner. So in a vertical manner. That's the movement. As we move the mandible, you can see the muscles are moving as well. So that's the infratemporal fossa dissection. So in real life, this is what you would do. You will not cut the temporalis muscle. You will not cut the lateral pterygoids because it will catch too much mobility. So I'm going to show you a few more video dissection that I've done, and just to have a overview again. So let me just bring this down again. So here you can see on the left side, on the right side, that's foramen rotundum, as you can see. That is the median nerve, as you can see. And that's how the infraorbital nerve, you can follow it backwards, all the way back until you come to the foramen rotundum. Now we're coming to the lateral plate of the lateral plate of the pterygoids. That's the sphenoid wing. We're going to use a sharp dissection of the superior head of the lateral pterygoid itself. That's the lateral pterygoid, the superior head. And as we dissect, we can already see the V3 coming into view as well. So that is the foramen ovale, and the V3 coming into view in another cadaveric specimen as well, as you can see. That's the V3, right? So let me move on to another one. So this is another dissection. Repetition is good because it gives you the landmarks again and again in different cadavers. Again, the infraorbital nerve, as you can see, that is the foramen rotundum. That's the median nerve. This is the maxillary artery with a descending palatine, as you can see, right? That's the median is here, the infraorbital nerve, and we have gone to the sphenoid wing, and this is the superior head of the lateral pterygoid. And again, we've pushed it down, dissected it, and you can see again the foramen ovale very, very clearly. And that is the posterior branch of the V3 as well. And you can see how the two heads of the lateral pterygoid, the V3, that is the shape of the foramen ovale, and that's the muscle fibers as well. And now another dissection I'm going to show you. So this is a very quick overview. That is the middle rectus muscle, and this is the inferior rectus muscle to put everything in perspective. And this is the infraorbital nerve that's coming from the orbit. And here you can actually see the optic nerve, optic chiasma, pituitary gland, carotid artery. And the same way, you can see the sphenopalatine, this sphenopalatine, the maxillary artery, the descending palatine here, as you can see. And then and these are the maxillary artery as well. And again, we can identify the infraorbital nerve quite nicely and how it's going into the foramen rotundum. And these are the branches. That's the median nerve. You can see the median nerve going very nicely into the median canal. And if you follow this median canal, it goes straight to the paraclival carotid, as you can see here. That goes straight to the paraclival carotid at the petrous apex, where the horizontal portion of the petrous apex carotid artery becomes vertical. And these are the branches of the two pterygopalatine nerve. And these are the pterygopalatine ganglion, as you can see here. All right. So I'm just going to go a little bit quickly because what I wanted to show you here is more of the infratemporal fossa. All right, there's the pterygoid plates, as you can see. So these are different dissection that shows you the same anatomy. Here, the fat has been removed from the infratemporal fossa. And here you can see the temporalis muscle. And how do I know it's a temporalis muscle? Look at the fibers. We're coming laterally, and you can see the fibers are all running downwards from superior to inferior, which is the temporalis muscle. Look at how big and chunky the muscle is. For us to identify the infratemporal fossa, we need to remove this muscle. To identify the lateral pterygoids, we need to remove that muscle. And here is a superior head of the lateral pterygoid that's being dissected away. And that gives us a very nice view of the foramen ovale, and that's the V3 again as well. All right. So now let's go to the Meckel's cave. Okay. So this is a very quick overview of the anatomy. Right. Here you can see this will be the Meckel's cave, the fifth nerve. That'll be the V1. That'll be the V2. This will be the V3, and this is the Meckel's cave. So the Meckel's cave basically can be identified by seeing where the V2 and the V3 joins together. This is a beautiful view of the third nerve, and that's the sixth nerve that's coming into view as well as going into the orbit. Another close-up view. Third nerve, sixth nerve. This is coming from the intracranial. That's the Meckel's cave. That's V1. That's V2, V3, lateral pterygoids. And so this forms the cavernous sinus, as you can see here. That's the cavernous sinus. V1, V2 is the lateral wall of cavernous sinus, whereas V3 is completely out of the cavernous sinus. And it's another close-up view. So this forms the Meckel's cave. So the best way to identify the Meckel's cave from transnasal is to follow the V2 backwards, and where the V2 and the V3 joins together, that forms the anterior part of the Meckel's cave as such. Then again, as you can see, the third, sixth, V1, V2. So this forms the cavernous sinus. This is the V3. So if we follow the V2 backwards and see where the V3 joins, we will be able to find the Meckel's cave in a dissection.
I'm
So
sorry,
these are
Professor. Can just to make to the audience clear, can you go back to the previous images just to clarify what we are seeing right now is a cadaveric dissection.
yes, it is, yes,
From upside, we are
from the
looking
top,
back, and we are in
yes,
the left side looking to the in front of us. All right?
correct, that's true.
Okay? I'm sorry because there's a lot of residents.
All
Someone
right, okay,
so they have to know exactly that this is not an endoscopic view. This is an anatomical specimen, and it is from an
from the top,
open approach. I'm sorry
right.
for interrupting, but this is
No,
essential
no,
for the
it's
people.
it's a very good point. So the idea why I wanted to show this is to show you how to identify the Meckel's cave. The best way to identify the Meckel's cave will be to follow the V2 back to find where the V2 and the V3 meets. So this is the anatomy from the top. Now let's look at the anatomy from the nose. So we're looking from the front. This is the left side, and again you can see this is the V1. So this will be the sixth nerve. This will be the V1, the lateral wall of the cavernous sinus. That's the V2, and the V3 will be going down here as well. So again, here will be the third nerve, the sixth nerve, the V1. So this will form the cavernous sinus, and this will be the V2, and the V3 is coming here. So if we remove the foramen ovale, here we can see how the V3 and the V2 will join together to form the Meckel's cave, whereas the sixth nerve and V1 and V2, so this forms the cavernous sinus. So the Meckel's cave is basically just slightly inferior and lateral to the cavernous sinus. So this is the way that I dissect the Meckel's cave. So in real life, obviously that lesion will be large, and you can actually use an IGS, but to dissect in a cadaver is a different story altogether. So again, this is a descending palatine artery. And again, you can see there are the descending palatine artery is always accompanied by two greater palatine nerve. And here you can see very nicely the two greater, that is the nerve and that's the artery. The two greater palatine and one lesser palatine. So again, this dissection, again, you can see the infraorbital nerve, as you can see, nicely exposed. And here you can see the foramen rotundum nicely exposed as well. That is the foramen rotundum. And that's the lateral wall of the pterygoid. And we can also see the radian here as well. So the lateral recess of the sphenoid sinus is basically a pneumatization between the foramen rotundum and the radian nerve. So the pneumatization between the foramen rotundum and the radian nerve forms the lateral recess. So in this case, it's a very nice lateral recess, and you can see how foramen rotundum and radian nerve. And now we are going to see the paraclival carotid, and you can actually make out the indentation of the V2 to the foramen rotundum. That's the foramen rotundum, and if you follow it backwards, you can actually see the V2 running along at the lateral recess, as a superior part of the lateral recess here, right? So what we need to do now is basically to remove by using a Carrison punch. So the idea is to do the dissection exactly like how we do in real life. We remove the anterior wall of the lateral recess, as you can see, and you can see that the videos that I'm showing are mostly unedited. The amount that we edit is very little, so that you have a rough idea how long the surgeries take as well, and the dissection takes as well. Now you can see this is the lateral recess, and this is where the Steenberg's canal usually has a CSF leak, and that's the V2 here. So what we need to do now is we need to dissect and follow the V2 backwards. So the first thing we need to do is to remove the mucous membrane of the sphenoid. When we remove the mucous membrane of the sphenoid, you can see now very nicely the indentation of the V2 in the lateral aspect of the sphenoid sinus, and that's the paraclival carotid, as you can see. Okay, so once that we can see the indentation of the V2 very nicely here, now the next step is to use a cuvette and remove the bone, follow the foramen rotundum, and slip the cuvette into the bony canal and remove the bone along the bony canal so that we can expose the V2. So that with this, we are now exposing the V2. And we can follow it forward until we can bring it down and expose the carotid artery as well. So now the paraclavial carotid has been exposed. And here we can remove the bone downwards. And this is where the V2 is going backwards. And down here will be where the V3 is. So this would be the area of the Meckel's cave, but we will identify and open it up a little bit more. So now let's identify the V3. So by using a Frias elevator, we're going to dissect and identify, remove the superior head of the lateral pterygoids. And with that, we will be able to identify the V3. There you go. That's the V3. That's the foramen ovale. So what we need to do now is to remove this piece of bone. That's the V2. And that's the V3. We need to remove this piece of bone in between. So this is an unedited video of the Meckel's cave dissection, and it gives you an idea of how the speed that this dissection can be done once you do it plane by plane and you know the anatomy quite well. I'm going to skip this video a little bit in view of time. It's basically more to show that how we're going to remove this particular part. Okay, so once we have removed that particular part there, okay, so again, you can see now I've used a Carrison punch to remove this part because I didn't have a drill during this particular dissection. There's a foramen rotundum, and that's V2. As I'm pulling the foramen rotundum, you can see how it's moving, and this is the V3. I've actually preserved the bone so that you can see how the foramen ovale is facing downwards. Okay. Now we're going to remove the bone in between. And as I said before, I didn't have a drill in this dissection, so I end up using normal instruments. So let me just go a little bit more quickly so we can go straight to the dissection itself. So here now you can see the infraorbital nerve. That's the Vidian's nerve. And now you can see the foramen rotundum with the V2 going backwards. It's an unedited video, so you see it almost live. And you can see how we can follow the V2 back to where the V2 meets the V3. So here now we can see the V3. I've actually left a ring of bone along the foramen ovale so that you can see how the V3 comes down. And look at the foramen ovale, it's facing downwards. That's why it's very difficult to identify. So where the V2 meets the V3, that junction here will be the anterior part of the Meckel's cave. So now we're going to cut the dural lining along it. And here you can begin to see V1 coming into view. That's V2, that's V3, and the area that they are joining here is the Meckel's cave. So that is the dissection of the Meckel's cave. So another overview, very quick overview. Again, you can see the final view in a few more dissections that I've done so that the repetition goes in our mind. Again, the foramen rotundum, we can follow the V3 backwards. And this is a good dissection because it shows you the cavernous sinus as well. That's the carotid siphon. That's the paraclavial carotid. So this here is the cavernous sinus. And here we can see the sixth nerve. That is the sixth cranial nerve here. That is V1, V2, and this is V3. So it shows us very nicely where the Meckel's cave is. This is the Meckel's cave. And also shows us the landmark of the Meckel's cave in relation to the cavernous sinus, which is just inferior to the cavernous sinus as such. Another dissection again. Again, you can see the V2. Follow the foramen rotundum and follow the V2 backwards. It takes us straight to the foramen ovale. So we've dissected out the foramen ovale. This is the dura of the temporal bone. and that is the foramen ovale, and that's the median nerve going into the paraclival carotid. And here you can see the again the cavernous sinus, that is this the paraclival carotid here, that is carotid siphon, and that is the sixth cranial nerve coming into view. That's the third cranial, there's a third cranial nerve, sixth cranial nerve, V1. That's the V2 that we are following backwards. So this forms the lateral wall of the cavernous sinus. And this here is the Meckel's cave, where the V2, foramen rotundum V2, meets the V3. That's the Meckel's cave. And here you can see how the V3 comes very nicely along the foramen ovale that's facing downwards. And you can see that the Meckel's cave is exactly where they meet. And here you can see the V3 and the branches and the posterior branch of the V3 going between the two heads of the lateral pterygoid muscle. So this is the foramen rotundum. Another dissection, the last two dissections anyway. This is the infraorbital nerve again. And again, you can follow the infraorbital nerve backwards. Sorry, let me just go back here again. You can follow the infraorbital nerve backwards, and then there's the median nerve. And here you can see the V3 coming into view, and that's the Meckel's cave, where V2 meets the V3. This is the Meckel's cave, and this is the middle cranial fossa dura. This is where the Meckel's cave would be. And the last dissection I'm going to show you before I finish today. Here you can see now an overview of infraorbital nerve, foramen rotundum. And if you follow the nerve back, we can see the V3 and the foramen ovale, and how the nerves are actually entering into between the pterygoid muscles, the superior pterygoid, the lateral superior part of the lateral pterygoid. That's the cavernous sinus again, as you can see. But what I would like to actually show you is how you can actually identify the petrous part of the carotid artery. That is the paraclival artery, and this is the horizontal portion of the petrous part of the carotid artery, and that's the cavernous sinus, and that is the sixth cranial nerve. So that gives us the anatomy of the entire Meckel's cave, its relationship with the paraclival carotid and the cavernous sinus as well. So the easiest way, identify the V2 and follow it backwards. But in real life, there will be a swelling there. By using an IGS, you can just drill the whole thing. So this is the YouTube channel that my department has got, and I hope that you enjoyed and you liked the dissection. I try to keep it as simple as possible to make it as practical as possible as well.
It was a brilliant one. So anatomical demonstration were pretty fine, and I think that you did everything step by step, showing any anatomical structure. So in order to go ahead, we have some times for questions. The first question that I would like to raise is that, of course, anatomical dissection do not represent what we are going to see in a live patient. However, those are essential to get information regarding what to do, what to follow, what we can expect if we're doing something. If in order to address the audience, do you think that there are some anatomical structure that you will have to take in consideration for bleedings during an approach to getting in there that could be potentially, difficult to manage?
That's a very good question. The reason why I do the dissection in a step-by-step manner is I think we should use all dissections like a flight simulator, a trial run for our surgery. So it's very important to use the same instruments that you use, dissect layer by layer. The three main conductors of infratemporal fossa and pterygopalatine. The nerve is the infraorbital nerve. The artery is the maxillary artery. The muscle is the lateral pterygoid. So if we know the anatomy of these three, then it becomes very easy. The part that bleeds the most of all is the pterygoid plexus. So we need to make sure that we do not go straight into the muscle bulk itself. So in a real life situation, like a schwannoma of the V3, for example, so you will have a large lesion that is distorting the muscles. So we need to remove the posterior wall of the maxilla. We need to open up the fascia. We need to identify the maxillary arteries, like how I did just now, and then clip the artery or push it down first. That means stop the bleeding first. Then we dissect the tumor away from the muscles without damaging any of the muscle. The minute you enter the muscle itself, then you will cause some amount of bleeding, oozing, and you won't be able to see anything. So planes are very, very important.
So let's start with the question. The first question comes from Saudi Arabia. I say that what are the equipments that we need for doing a proper dissection?
The equipments that we need are more or less like what I showed just now. What I do is whenever I do my dissection, I try to use the same equipments. So to remove the posterior wall of the maxilla is by the simple kerrison punch. A sickle knife in my hands is, in my opinion, is the best tool to remove fat along the imax and the thyroid plexus. It should be sharp enough so that we can cut precisely. We can actually mobilize the imax by using a sickle knife, but don't cut through it. It's just a gentle traction. But once we are inside and exposing a tumor in the infratemporal fossa, then we probably need a forehand approach. So somebody will need to come and hold the tumor while we dissect the muscles away. This can be used by a simple Freer's elevator or the sickle knife. The most important thing is the plane. Preserve dissect the tumor away from the muscles in the right plane.
The other question from France is what are the pathologies that can be reached in this area?
It's a good question. So the benign ones will be schwannomas of V2 or V3. That's the benign ones. Sometimes we do this dissection here quite often for nasopharyngeal carcinomas. Quite often tumors enter into the pterygopalatine space. And sometimes we have tumor that goes into infratemporal fossa that we resected as well. So we've actually written a chapter on malignancies, endoscopic resection of malignancies in infratemporal fossa as well by the books by Aldostam. And also angiofibroma. That's a very common area where infratemporal fossa is addressed. And if you see, the dissection of angiofibroma is to mobilize the tumor and then at the same time dissect the muscles away without touching the musculature of the tumor itself.
Another question from Argentina. What is the differences between Cavazzi triangle and Meckel's cave?
The Kawase triangle is more of a neurosurgical approach. It's an open surgical approach. So that is the approach to the carotid artery region to come into the Meckel's cave region. So it's a very good question in a way, because Meckel's cave, to identify the Meckel's cave from the nose, in real life, it will be very easy because there will be a tumor that is large and you can actually see the bulge and use an IGS. But in a cadaveric dissection where there is no tumor as such, the easiest way is to use the V2 and go backwards to the Meckel's cave.
Okay, so let's go back here to the questions from the audience from this application. What are the landmarks? So Sujan is asking, what are the landmarks for pterygoid wedge and how do we safely remove it and any important structures there?
The pterygoid wedge is where both the medial and the lateral pterygoids meet. So that is the body of the pterygoid itself, which is the pterygoid wedge, where both the medial and lateral pterygoid wedge meet. So if that area is pneumatized, like a lateral vessel with sphenoid sinus, we can remove it quite easily, as how I showed just now in the Meckel's cave dissection.
Okay. So another question from Amrish. JNA extension to intertemporal fossa can be done endoscopic.
Oh yes, of course, yes. We do it quite frequently. We have removed tumors all the way up to the TMJ joint as well. But the trick is to respect the planes. That means the same style again, middle maxillectomy or endoscopic Dankers if required. Remove the mucosa from the posterior wall of maxilla, identify the arteries, find the plane where the tumor goes between the muscles. Do not cut the muscles, do not damage the muscles, but hold the angiofibroma with traction and then peel the muscle away. It's all about planes.
Okay, so another question from fellow Santos. Do you use embolization or you use another preoperative bleeding control?
For angiofibromas that goes into infratemporal fossa, where sometimes the IMAX is distorted, yes, we will embolize. But for malignancies, usually embolization is not going to help very much because the bleeding comes from the pterygoid plexus, which is the venous plexus. So the only for angiofibromas that are extensive, we embolize, but most of the others we do not.
All right. So there's a lot of question for surgery, but please do remind to the audience we are not talking about pathologies today. The focus is for anatomy and dissection. So we will go through that hopefully in the future with Professor Prepageran in the future. Today we are only discussing about anatomical dissection. So in order to do it, please keep on in the field. We cannot discuss other things. So another question, less from YouTube. The question is coming from Germany, and this colleagues is asking, do you think that mobilizing the infraorbital nerve could let you do betterly posteriorly or not?
By mobilizing the nerve, whether we
Yes.
can go further posteriorly. But the infraorbital nerve runs in a sling. It is not so, it doesn't come down very far. So there is no need to actually mobilize it as such in real life because it does not really come in the way of dissection. The majority of the tumors are usually much lower because and the infraorbital nerve actually runs along the orbital floor. So it does not really come into the field of dissection.
Another question, this is come from Russia. What are those instruments that you're using to elevate and to reach to the foramen ovale? Do you have to use the Freer elevator to mobilize a superficial dissection? I don't really get this question. It's not very clear, but I think that he's asking if there's a fascia or you have to do superficially to reach uh,
All right.
to the
So
foramen. I don't
this
know.
this dissection to find the V3 is we need to go subperiosteal to dissect away the attachment of the superior head of the lateral pterygoid to the greater wing. Only then we will be able to identify the V3. If we go into the muscle itself, we will not be able to get a clean dissection of V3. There'll be too much of oozing and bleeding, and we will never be able to find V3. I usually use a sickle knife or the Freers. I find if we keep surgery simple, life becomes simple as well.
Good. So last question. We don't have time anymore. Gaurav is asking a question which is okay for surgery, but also good for this topic. What is the landmark beyond which you will need a lateral approach, such as a transoral port, to mobilize the tumor invading the infratemporal fossa? This is interesting.
That's a good question. I would actually look at how large the tumor is. So if the tumor is behind a substantial amount of temporalis muscle or posterior to a big chunk of the lateral pterygoids, then a lateral approach will be much easier. Because then you will have to go through the entire temporalis muscle. You will have to go through the entire lateral pterygoids, and the damage that you do to the patient, the trismus that the patient is gonna have, the amount of oozing you're gonna have is substantial. So anything that is behind the temporalis muscle as well as the lateral pterygoids, I would probably do an open lateral approach.
I remember when we were in Varese, we were doing some dissection, and Paulino told that the plexus that is behind the plates is usually covered with some fats, but it's over there. There's when you're countering bleeding, that will put you in a tough phase, but you have to manage it to get posteriorly. So,
Exactly.
do you think that to preserve this kind of bleeding, what are the mandatory procedure or steps that you have to get it in there?
That's a very good question. So usually the pathology that we deal with will have obliterated that space. If the pterygoid muscles and the plexus are involved, if it's in the medial aspect. So the pathology that we're dealing with would have actually obliterated the space. So a nasopharyngectomy, a malignancy, the sphenoid sinus that's going laterally. And the angiofibroma, for example, or the V3, we do not even touch the plexus because we are lateral to the plexus. So each and every surgery is tailor-made according to the location of the pathology itself.
Great. So I think that for now everything is very very clear. We had a lots of questions. For anyone interested, once again, we will put the email in the link from Professor Prepageran for any other question. However, in case anyone interested, next appointment is going to be Tuesday 9th of June at 2 p.m. We will go 2 p.m. Rome zone time. We will have another dissections from Professor Prepageran, who's going to talk about the clival region, right? And what else, please?
So what we will do on the 9th will be, we will do the sella, paracella, supracella, and the clival, because they're all interrelated. And I think you will like the dissection. And again, I would be happy to show clinical cases of infratemporal fossa in the future if this COVID goes on.
Great.
And
So
again, thank you very much for having me.
yeah, it was a great pleasure. Before closing, it's I do think that we have to give some regards. There are a few regards from the audience. Of course, I have to thank Asia for letting me have your contact. So Asia is doing very very good. And then there's regards from Amrish Deshpande. Please give my regards to Professor Prepageran, was his fellow for anterior skull base in 2015. The Dr. Teja Shri from India. Okay, so thank you everyone for
Thank you. Thank you.
attending. Thank you everyone for attending. Thank you, Professor Prepageran. We will give information tomorrow for the meeting of the 9th. Link always the same. Everyone can use the same link, the same ID number for all of our lesson and teach. Don't forget, tomorrow we will have another meeting with Shokatala. So we were going to have a GPA in the ENT. Next week, many others. So thank you, Professor Prepageran, for being with
Thank you
us.
very much.
And I'll talk to you very, very, very soon. Thank you.
Thank you.
Everyone.
Bye-bye. Thanks.